Hi everyone, my name is Bryn Kostniuk, and I'm a grad student at the University of Alberta and a research assistant with the Inner City Health and Wellness Program at the Royal Alexandra Hospital in Edmonton. Today I'll be sharing some findings from our research team's evaluation on the Royal Alexandra Hospital's Supervised Consumption Service in the hopes of contributing to larger discussions on improving acute care for people who use drugs. The title of this study is I Felt Safe There, Implications of an Acute Care Supervised Consumption Service for the Hospital Risk Environment. Before we begin, I'd like to say that over the past 2 years, I've been an employee of and received funding from the University of Alberta. I've also received funding from the Canadian Institutes of Health Research. I have no conflicts of interest to disclose otherwise. So, a little bit of background information before we get into the study. Acute care hospitals are generally a high-risk environment for people who use drugs, as they are criminalized spaces that often enforce bans on illegal drug use. From a public health perspective, this approach has been largely counterproductive. It's not only ineffective at reducing and preventing drug consumption, but it actually worsens harms to people who use drugs. So, for example, these patients frequently report having to consume substances in hidden and unsanitary spaces of the hospital, often alone and with unsterile supplies. So in April of 2018, the Royal Alexandra Hospital implemented North America's first acute care supervised consumption service, or SCS, as a strategy to help mitigate some of these harms. However, it was developed largely ad hoc, as there is currently a paucity of SCS integrated into the acute care hospital setting, and there's a lack of research in this area. To address this gap, we aim to understand patient perspectives on the provision of the Royal Alex SCS. Namely, we wanted to examine barriers and facilitators to using the service, and how the SCS might impact patient care and hospital outcomes. It's important to note that this project is part of a larger evaluation of the SCS that we are conducting. We are also examining administrative data from the site and staff perspectives on the SCS. So we first secured ethics and operational approvals from the U of A and Alberta Health Services, and we also engaged extensively with people who have lived experiences using drugs via the Inner City Health and Wellness Program's Community Advisory Group. We then adopted a focused ethnographic method and conducted 28 semi-structured interviews with patients who had been offered to use the SCS. Interviews were about an hour long, and we conducted them between May and November of 2019. We then used the risk environment framework to help guide our interpretation, which outlines how the environments of people who use drugs can either minimize or worsen drug-related harms. In the context of the current study, we used the framework to help us ultimately identify actors and structures that shaped SCS uptake and its impacts on patients. So who did we end up talking to? Of the 28 patients we interviewed, 20 had used the SCS during a hospital admission. On average, patients were 36 years old and just under half self-identified as women, while close to 60% identified as Indigenous. Patients had been using illegal drugs for about 18 years, and most people primarily used opioids, namely heroin and or fentanyl. Getting into some of our results now. First of all, patients spoke frequently about the impacts of drug law enforcement on SCS uptake, and we found that there was some duality in this respect. So some participants actually avoided using the SCS as they generally cited low trust in the service. This group of patients described that they thought it had ulterior motives, such as to arrest patients or kick them out of the hospital for using illegal drugs on facility grounds. As one participant described, I was worried about thinking the cops were around there and going to arrest me for doing my dope. However, many participants also perceived the SCS to be a safe space that essentially protected them from formal or informal sanctions that they could experience via local police or hospital security outside of the SCS. For example, one man told us, "You don't have to squirrel away in a staircase and risk getting caught and getting kicked out of the hospital, because if they catch you doing dope where you're not supposed to, they'll just kick you out." In addition to drug law enforcement, many participants reported worries about changes to their patient care if they used the SCS. This included concerns about changes to pain medications, changes to medical care, such as being moved to a different ward or receiving less frequent care. And the primary concern that participants reported was judgment from hospital staff. So, for example, the top quote highlights this concern. "That's one reason why I won't go there. I'm really kind of afraid that they're going to look down on me again because of my use." Unfortunately, some patients did experience real changes to their care following SCS use. For example, the bottom quote highlights changes to medications, as one participant said, I heard one nurse talking to 4 other nurses about how I was going to the safe injection site. We really shouldn't be giving her anything. I poked my head around the door, she started to whisper. For some patients, these real changes did deter ongoing use, but for others, the benefits of using the service seemed to outweigh these repercussions. In response to these concerns about local drug law enforcement and changes to patient care, support from hospital staff, especially the addiction medicine consult team called ARCH, seemed to encourage uptake and ongoing use of the SCS. One participant described this nicely. She said, "I didn't think the SCS was real, but then I got comfortable talking with the nurses and got to know my addictions counselor and my peer support worker. It became a piece of cake." Encouragement from the addiction medicine consult team's peer support workers was particularly influential amongst participants, and this seemed to be related to their ability to provide relational care to patients. For those of you who don't know, peer support workers are people with lived experiences using drugs and who work to provide various supports to patients under the care of the consult team. So the bottom quote here highlights the critical role of peer support workers in encouraging uptake nicely. I felt really comfortable discussing the SCS. My peer support worker kind of came from the same place, being able to relate in that way. Lastly, we found that the primary impacts of the SCS on patient care and hospital outcomes were threefold. First, patients reported minimized drug-related harms in the hospital as they accessed the service for emergency overdose care, and most notably, to avoid using drugs in unsafe areas of the hospital. Namely, the SCS helped patients circumvent pressures to consume drugs in patient and public washrooms. As this participant said, "It's literally saved my life. If I wasn't there, I would have probably been in a bathroom stall." Participants also accessed the service for sterile supplies and to dispose of supplies, which help prevent harms to themselves, other patients, and staff. As this patient said, "Nobody's going to get pricked, especially the nurses, by someone's dirty needle." Second, patients described overall improved care satisfaction. So, for example, many told stories about prior negative experiences in acute hospitals, especially related to drug stigma and drug law dynamics, but they perceived that the SCS made their stay better as they didn't have as many worries surrounding substance use during their stay. And this brings us to the third impact, which is improved self-reported hospital retention. Patients felt that having access to an SCS helped them stay in hospital and complete their acute care treatment. The participant in the bottom quote told us how he's often been treated rather poorly in hospitals, but that accessing the SCS during his hospital admission this time around made his stay better and ultimately enhanced his retention. He said, "Normally, I wouldn't sit in a room full of 4 or 5 patients. I'm the one that gets no curtain or no TV. I wouldn't normally stick around, but being able to go there is like a positive thing." So to wrap things up, I'd like to share some key takeaways. Overall, patient perspectives highlighted that provision of SCS in the hospital setting may help reduce some risks associated with in-hospital substance use. Given that hospitals typically enforce bans on illegal drugs, providing a clean, safe, and decriminalized space was extremely important for increasing overall safety. Patients also reported improved care satisfaction and self-reported retention, which is especially important considering the long-standing mistreatment of this group of patients, and may point to the potential for SCS in the setting to help foster a more positive hospital environment. However, despite improved satisfaction, it is important that we consider the reported barriers and repercussions, as these issues obviously need to be addressed moving forward. To address these barriers, patients generally suggested that more mandatory education and training on substance use and inner-city health and wellness is needed amongst staff and local drug law enforcement. However, it is possible that ensuring uptake amongst all patients might be difficult unless illegal drugs are ultimately decriminalized, given that the effects of prohibition evidently trickle down into the hospital environment. So that brings us to the end of this presentation. Thank you all so much for listening. I'd like to thank Alberta Health Services, the University of Alberta, the ARCH team, AWARE, CIHR, and the Royal Alex Hospital Foundation for supporting us in this research, and a special thank you to the participants for sharing their knowledge and expertise. If you have any questions or comments, you can reach me at bkostanuk@ualberta.ca. And if you'd like to learn more about our team's research, including the SCS evaluation, you can visit our website at ishrip.ca.